here, but really wanted to focus on endocarditis and pericarditis and to focus on really the pathophysiology and the etiology of both of those, the risk factors for development of either of those, and then how we diagnose and how we manage both of them. All right, so kind of keep that in mind as we go through this. Now, we'll start off with endocarditis. And what I want to say is most of the information that is in this talk is through a really fantastic statement that was put out in 2015. And I'm happy to send to Cecilia that she can send out to the group as well too, from the American Heart Association. And that was a consensus statement on management of infective endocarditis in childhood. And it's really well written. I would highly encourage anyone to look at this, and I'm happy to facilitate and send that on. So we're going to go through some highlights here. But essentially, the definition of endocarditis is an inflammatory process, which is a very non-specific process that affects the endocardium or inner laying of the heart and the valves that may be infective or non-infective in origin. And as a fun fact, it was first described by William Osler. Epidemiology, as far as in pediatrics, the annual incidence rates in the US is anywhere from 0.05 to 0.12 cases per 1,000 pediatric admissions, so not a very frequent diagnosis. And the overall frequency of endocarditis diagnoses that we've seen in children really is towards those who've had a previous history of cardiac surgery. So as opposed to the adult world where endocarditis is associated more with things like intravenous drug use and other comorbidities and sometimes secondary disease processes, it really is more related to previous cardiac surgery for the most part, what we're finding. We're also finding that now in the current era, we have more children surviving congenital heart disease, surviving longer and longer. And with that, there has been a subsequent uptake and increase in endocarditis diagnoses as well. So that's all to say, I think it's an important diagnosis for anyone to understand and to think about when you're caring for this population as well. That to be said, for children with normal native anatomies, it's not just within those with congenital heart disease. The presence of a central line has actually been demonstrated to be the largest risk factor. And in about 8 to 10% of cases, there really is no identifiable source in the end. And so thinking about the pathophysiology and how this actually occurs, this inflammation and usually infection of the endocardium itself, you have to have some sort of endothelial injury. And this often happens due to turbulent blood flow. So if you think about from our standpoint, we have lots of things that can cause turbulence. So either it's a post-op and it's a prosthetic material or a valve in place, or it's just the lesion itself in a normal valve or tissue. And this leads to a deposition of fibrin and platelets. And ultimately, this term is called non-bacterial thrombotic endocarditis. Essentially, that is a collection of fibrin deposition that is making that area or that tissue more susceptible to infection, usually from a bacterial origin, and then ultimately become colonized and develop these vegetations. Okay, that's the main predominant theory. There are other possibilities, but that's the main one. And anyone who ever is going to take a board exam or anywhere, this is a buzzword and a keyword that oftentimes is on board exams: the non-bacterial thrombotic endocarditis. That's the setup for what ultimately becomes colonized and develops vegetations. And so on histopathology, there's two main things that you really need to have and that you'll see. And the first is damaged or denuded endothelium is necessary for that initial pathogen colonization of the cardiac focus. And then it's oftentimes gram-positive cocci that have multiple adhesions that serve as virulence factors or make it more likely for them to be able to attach to the host cell or substrate. And this is what the initiation and propagation of the vegetation is. And if we look at this on histopathology, what I thought was just interesting is on the left side here in slide A, that's just not as zoomed in. And then when we zoom in here, all this dark markings here, that's actually the bacterial stain. And so you can see you have actual bacterial infection on this is, excuse me, this is a valve itself and then a vegetation. So you have the bacteria themselves, and then you have lots of neutrophils. All these little black dots are neutrophils. So it's the infection and it's the inflammation leading to the pathology here. And so the main causative agents, there's a lot of them. And so I'm just going to briefly highlight some of the general stuff. And overall, what I will say is this is changing over time. So it depends on what study you read. But it's about, about 40 to 50% are staph species. So Staph aureus or Staph epi, make about 40%. And then Streptococcus species tend to be about 40% as well too, although that does change a little bit depending on the patient, depending on the study and how they looked at it. And then other species are things like beta hemolytic strep, enterococcus, or the HASEC group as well too. And so up in the top, I just like looking at a histology slide. So that's your staph, the clusters, you have the change, your strep, and then this is enterococcus. And so associations that you should think about, patients with congenital heart disease versus those without congenital heart disease. Those with congenital heart disease tend to be more likely to have the strep species, and those without congenital heart disease tend to be more affected by the staph species. And some of this is all related to, as I said, the indwelling central lines is more of a risk factor for those without congenital heart disease. Age also appears to play into this. So those over 1 year old tend to be viridian strep, whereas it's the infants that are affected more by coag-negative staph, Staph aureus itself, or even Candida. And then those with prosthetic material, including valves, are more affected by Staph aureus or coag-negative staph. And if you also think about the presentation of this, patients who present acutely ill, decompensated, those are actually more likely to be staph infections as opposed to the subacute presentations happening over time. Those are more likely to be related to viridian strep or enterococcus, and then catheter associated once again is staph as well. These aren't perfect, but these are just kind of general principles that have been demonstrated in the literature. And then I put this slide on here just to think about all stuff in our specific patient population, those with congenital heart disease, and some of the risk factors. And so, endocarditis has been described as association, while rare, but has been described as an association with VAD. So I should have been Berlin heart here. Mechanical valves have been associated. And then even things like atrial and ventricular leads. So this patient has a pacemaker within indwelling leads, those have been associated and is a really feared complication of that technology. Things like stents that we place, all of these have a possibility of becoming infected. Conduits, RVPA conduits here, I think this is a Ross procedure that they're demonstrating, can be associated. And then even things as indwelling lines as well, as we mentioned. So a lot of the stuff that we do in our congenital heart disease population does place these patients at an increased risk. Risk for actual having a lot of complications due to endocarditis and a more severe presentation. Well, these are also things that tend to be in our population as well too. So prosthetic cardiac valves themselves are a risk factor as well. If it's on the left side, that's a higher risk for complication, and that's because of embolization of essentially the vegetations or the bacteria itself. Staph aureus tends to be specifically a difficult to treat and quite virulent, and then fungal infections as well too. And then just prolonged symptoms or cyanotic congenital heart disease, and those with shunts really are at a higher risk for poor outcomes. So getting into this though, we should probably talk about how do we actually diagnose it. And I think, most people at some point have probably heard about the Duke criteria, and these have been revised several times, but the major Duke criteria, you have to have usually one of these, one major, although there is a specific type that you don't have to have any, and we'll talk about that. But for the major criteria really are a positive blood culture for endocarditis. And these are with typical organisms from greater than 2 cultures. So either viridian strep, Streptococcus bovis, a HASEC group, or community-acquired staph or enterococcus without another primary focus. And I think that's important, that it has to be, there's not another specific focus that you have that is causing that. And microorganisms consistent with endocarditis from persistently positive blood cultures. And there's specific guidelines here, having 2 positive blood cultures drawn greater 12 hours apart, or the majority, so 3 of 4 positive blood cultures, irrespective of timing. So if you're gonna just obtain blood cultures once, you actually need 4 to truly make the diagnosis. Or 1 positive blood culture from Coxiella. That's just as a separate kind of anomaly one you have to remember. And then there's other major criteria is some evidence of endocardial involvement. And so it's usually via echo images, whether that's transthoracic or transesophageal. And that really what they are looking for, you're looking for an oscillating intracardiac mass, or an abscess, or a dehiscence of a prosthetic valve, or a new valvular regurgitation that is new onset and there's no other explanation for. The minor criteria for the Duke criteria would be a predisposing condition, which in our patients would be, history of prosthetic material or congenital heart disease itself, cyanotic congenital heart disease, fevers, so persistent fevers greater than 38, The vascular phenomena, and I'll show some photos of these. The immunologic phenomena, these are like the Osler's nose, the Roth spots, the things that we talk about. And then microbiology evidence of a positive blood culture that's not the major. So it's not the typical bacteria, but otherwise meets criteria, can also be a minor criteria. Looking at some of these are the Janeway lesions. These are the red dots that happen on the hand, and those are not painful. And then Osler nodes are the painful ones on the palms and as well. And then the Roth spots are in the eye, and they're these kind of punctate hemorrhages with a white central clearing, are Roth spots. And those are all, minor criteria for the diagnosis of infective endocarditis. And then kind of putting this together, we have our major criteria and our minor criteria, and then we have to figure out how do you actually make the diagnosis. And so really from a clinical standpoint, you have to have 2 major criteria, or 1 major and 3 minor criteria, or 5 minor. This is something that oftentimes we have to look up, so I don't necessarily expect anyone to remember it, but at least as you walk away from this, you should know that 2 criteria exist and that there are specific criteria you have to make, okay, for this. And so, the blood culture recommendation, as I went over, I do think it's important, and it affects how we actually obtain them. And really, the recommendations put forth by the AHA are that they should be drawn in settings of patients with fever of unexplained origin and a pathologic heart murmur, a history of heart disease, or a previous history of endocarditis. And that's class 1 recommendations. And the recommendation is to obtain at least 3 blood cultures on the first day. And if there's no growth, then to obtain 2 more on the second day as well. Now, they do note that in patients who are not acutely ill and whose blood cultures remain negative, it is actually acceptable to withhold antibiotic drugs for over 48 hours while you're obtaining additional blood cultures to make the diagnosis in that case. And then in patients with acute infective endocarditis who are severely unstable, 3 separate vein punctures for blood culture should be performed over a short period and an empiric antibiotic evidence, the therapy initiated. So really this does involve our clinical decision of how sick the patient is as we decide how we are going to treat and whether or not to do empiric antibiotics. And so I think it's important to know that the guidelines support empiric antibiotics, but that's in the setting of those who are severely ill or unstable. The imaging modality of note, as I mentioned, you usually use either echo to start with, and the recommendation here actually is to start with transthoracic echo, especially in the pediatric population. Patients who are less than 60 kilos, oftentimes you can get a full view and don't need to do the transesophageal. Transesophageal is classic for it, and the recommendation is to use it if you need it. But oftentimes in small patients, we're actually able to get a complete view without having to do the transesophageal. So know that compared to adult studies, that adult recommendations, that oftentimes do recommend the transesophageal echo to look at the left heart, and they get better views of the left atrium as well. Based on our patient's body habituses, oftentimes you can get it with the transthoracic alone. And this is just the recommendation that it is, you can do the transesophageal for infants who've had chest wall disruptions from previous surgery in thoracic cage. That is recommended if you are not able to actually get the actual view. Oftentimes it actually also can be helpful if you really are looking for an aortic root abscess as well too, especially if there's prosthetic material there that can make it difficult to actually get a full view due to artifact with the transthoracic echo. These are some brief still images here of real simple. So, right-sided endocarditis here. This is a echo image of the base of the heart swimming up to the base and parasternal short. This in the middle is the aorta. This here is the right atrium. This here is the left atrium. And you're not really seeing the atrial septum here. It's not in your plane. But then this is what should be the tricuspid valve, should be nice and thin in leaflet. You can see here, these are thick and there's this giant vegetation. So this is a massive vegetation on the tricuspid valve. And right-sided endocarditis, I just did a few images to show, tends to more show up in our patients with body swelling and edema of the extremities. You can have vegetations and emboli that become essentially PEs. You can see here, this is a large filling defect from a large vegetation that has embolized from the tricuspid valve as well. And then I just put this on here to show myself an image of the big liver to show obviously hepatomegaly goes along with the right-sided heart failure. And those are usually the signs that you'll see. This is in contrast then to left-sided endocarditis. And this here is an echo image. We have the right atrium, right ventricle, and then orienting yourself. This is the left atrium and left ventricle with the mitral valve. And this, of course, is a giant vegetation as well on the mitral valve, so showing a left-sided lesion. These are the ones that tend to present more. You can present with evidence of LA hypertension and severe congestive heart failure, so bad pulmonary edema, poor peripheral perfusion here. I like that old classic image. And then this is actually a mycotic aneurysm as well too. When these seed, they tend to go systemic and can go to the brain, and this is evidence of a mycotic aneurysm as a complication. And so antibiotic therapy, there's lots and lots of regimens, and I put in here, these are the actual recommendations for the treatment. And I'm not going to go over all of them aside from just summarizing that when it's unknown and when it's an empiric, then oftentimes it's going to be, an ampicillin containing plus gent. And then if you have a prosthetic valve, you add rifampin. And depending on how sick your patient is, you consider vancomycin as well. There's lots and lots of lengths depending on what actually, if it's a native valve versus the prosthetic valve and what the microbacteria have shown determines how long you treat. But in general, it's at least 4 to 6 weeks. And the recommendation really is to have your infectious disease colleagues assist with this, since it is a long-term antibiotic treatment course. And this here is the, it's at least, 4 to 6 weeks, sometimes even longer, up to 6 to 8 weeks to attempt treatment of that. And the recommendation is to have bactericidal agents as opposed to bacteriostatic agents. And that's based whenever possible as well too. It is acceptable to use outpatient IV antibiotics for endocarditis, especially for these long-term ones in patients that you are hemodynamically stable. They have negative blood cultures after treatment or during treatment as well, and are not at risk for complications, and that you can have established follow-up. It is actually acceptable to, once you've established your regimen, to manage these outpatient at home. So this is the summary of the therapies. Really, it's going to be using your blood cultures and your sensitivity patterns to guide the therapies, and that your empiric coverage here is going to be beta-lactams, aminoglycosides, and adding on vancomycin if your patient is sick or has ongoing indwelling lines. And then if there's a prosthetic valve, that's where you're going to add the rifampin as well. And as I said, extended duration of therapy, at least 4 to 6 weeks, sometimes longer. These are if what happens when we can't treat it just medically. And so there are multiple indications for needing a surgical intervention here. And there's 3 main categories, and that's for significant vegetations, valvular dysfunction, or perivalvular extension for any of these. And there's very specific criteria for those. Oftentimes you have to have a large vegetation that is in adults, the adult literature that's been extended down to peds is greater than 10 millimeters. So a huge vegetation that at least has one embolic event. So you have to have embolism plus big vegetations to go to the OR for surgery just related to a vegetation itself. Or if the vegetations themselves are increasing despite your therapy and the patient's hemodynamically, those are significant, then the indication is to go to the OR. For valvular dysfunction itself, these are related to acute aortic or mitral insufficiency and signs of ventricular failure, or heart failure that you can just not medically manage, or a valve perforation itself. These are the criteria for going to the OR for that. And then perivalvular extension, this is when you have abscesses that actually form within the root, as well. And these, that's another indication for going to the OR. And so these are just some of the examples that I went over. This is a large vegetation on the aortic valve itself, and another large one on the tricuspid valve. These would be indications for going to the OR based on their size if the patient was symptomatic. Same thing with acute valvular dysfunction. This is a severe aortic regurgitation. I mean, you can see the LV is dilated, and same thing here as well too on the tricuspid valve side. Severe regurgitation, dilation, and potentially even a rupture with both of those. Paravalvular extension itself as well too can ultimately present as heart block because based on the location of where these large abscesses can be, that's right next to the conduction tissue. So it has been described as a new onset heart block in the setting of a perivalvular infection and endocarditis actually is an indication for going to the OR because oftentimes these are just not amenable to medical therapy and need surgical debridement. And then this essentially is just the recommendation that in general, in patients with infective endocarditis, they recommend the true degree of illness not being considered a limitation to surgical intervention because the alternatives to delay or defer surgery can have dire consequences. And this oftentimes comes into place that the patients who are acutely critical ill who come in sometimes with medical therapy is not able to actually intervene on that, and you just have to go for source control essentially and go to the OR. And then mycotic aneurysms may occur in systemic vessels and are particularly dangerous in the cerebral circulation. So the left-sided ones are more dangerous, and this could be a surgical indication as well too because of the risk of a mycotic aneurysm rupture. And so it is recommended that prophylactic surgery to prevent a primary embolic event, though, is not recommended given the lack of benefits. So just because your patient has a vegetation as a prophylaxis is not recommended. It really is having those all-out hemodynamic indications that we talked about before and meeting those criteria that they actually recommend going ahead as opposed to doing it prophylactically. And then just a word about the dentist as well, because we talk about this as well. How big of a risk is the dentist? Well, dental for endocarditis, dental procedures have been demonstrated to have bacteremia in children after dental procedures. This depends on the study. And if you look at the ranges, after tooth extractions, it's anywhere from 0 to 96%. After teeth cleaning and electric toothbrushing, some studies have shown 0% with bacteremia, some have showed up to 80%. Restorations, dental injections, other manipulations, there's a wide variety of bacteremia. So it can exist and it has been demonstrated to exist in literature. However, what hasn't been diagnosed is, you see with numbers this large, we would really assume that if the dental and bacteremia was such a huge risk with dental procedures, then I think you'd actually expect it to be a little higher risk overall incidence of endocarditis. And so these are all the different bacteria that have been recovered from blood after dental procedures in children. I never expect you to remember it, but this is all just showing there are a lot that can be isolated after the dental procedure. And so because of all of this and those two kind of points, the AHA has actually recommended, as well as the European guidelines have recommended a shift towards this focus on antibiotic prophylaxis before going to the dentist and more focusing all the efforts on maintaining just good oral hygiene in general and preventing oral disease. And so that being said, those with a cyanosis and specific, dental issues, it really is imperative to maintain optimal oral hygiene for them, and that for the highest risk groups, you do consider antibiotic prophylaxis. And these high risk groups for SB prophylaxis are the ones that we often talk about. Those with prosthetic heart valves, those with history of infectious endocarditis, and those with congenital heart disease, either unrepaired or cyanotic disease with shunts or conduits, completely repaired with prosthetic material for 6 months, or repaired with residual defects adjacent to the site of a prosthetic patch or device, we would recommend going ahead and doing SB prophylaxis beforehand. And then cardiac transplant patients with a valvulopathy or regurgitation is also recommended. And the prevention itself, as I talked about, good dental hygiene, disinfection of wounds, eradication of bacterial drainage, and being careful with antibiotic use, as well as careful and being mindful about the central catheters that we place. And so what procedures required SB prophylaxis? Well, those with the dental procedures, if you're actually going to manipulate the gingiva or the tooth itself as well. Respiratory procedures, if you're actually doing an incision or biopsy of the respiratory mucosa, or in the setting of a treatment of an active infection, then you would recommend doing prophylaxis during that time. But in those involving infecting skin structures or muscle, we do recommend SB prophylaxis if you're doing a procedure at the time. But there's not a recommendation for GI or GU procedures. anesthetic injection through non-infected tissue, just doing, dental radiographs, or, shedding of primary teeth, you do not need to do SB prophylaxis, or just, adjusting braces is not a necessary indication. And so I think with that, just based on timing, I'm going to have to unfortunately step away, but I'll do pericarditis. I have a couple more sessions with everyone, and so I'll be sure to get through this as well too. Okay, I know you guys have a break right now.
We'll rearrange another time for pericarditis.
And I'm happy to take questions via email as well. Okay.
Perfect. Thanks,
everyone.
So everyone, our next session begins at 3 o'clock. So there's about a 20-minute break. I'm also about halfway through of sending your exam results, so you could also look at your emails. Hi, Alex.
No, sorry, I just realized that I was on mute. My apologies.
That's okay.
I think we should actually do a study in that basically looks at how quickly people can realize they're muted and unmute when it's time to speak. Can I start?
Yes.
Oh, lovely. Thanks so much.
So everyone, this is Dr. Alex Flo, and he's a cardiac intensivist in our critical care unit, and he's going to talk to you on myocarditis.
Okay. As soon as I'm able to show my slides, I will do just that. Let me see. So can you guys see my slides?
Not yet.
Not yet. Okay, so effectively, I haven't done my job. Okay, let me try this again.
Yes.
Can
Now
everyone see my slides now?
Yes.
Okay.
It's
I'm
also bright.
I can also see that I've got a closed captioning going on, so
Yeah.
lovely. Anyways, good afternoon, everyone. As Cecilia said, I'll be talking